All right, everyone, thanks for being here. Thanks for coming back in. My disclosures, I feel that it's ironic that in an industry course we all skim through our disclosures very quickly as though there's something to be embarrassed about. Well, Smith & Nephew invited us all here today, and a brief word, in my opinion, on the evolution of industry as it relates to us as surgeons is in the bad old days, there used to be a lot of conflict of interest. There used to be payment for simply usage and for influence, and I would contend, luckily, that all is gone. And now industry really provides a crucial role as finances are tight. Academic departments and academic societies such as ANN and AOSSM, et cetera, can't afford to put on beautiful courses like these. You know, the specimens that we have are unbelievable. The instruments that we have are unbelievable. And as a surgeon, industry gives us research support, fellowship support, and it allows us to instruct our peers. And so I think we're all very lucky. So I'm very grateful to be invited. I would like to give, as I did last year, I like to really fully delve into my disclosures and really take ownership of that. So I just have a very brief photo essay, perhaps a morality play on the enticements of the French Quarter. And so this was last year, actually. Again, Abby does a beautiful job organizing this course, and the World War II Museum, I'm a big fan. I love Stephen Ambrose, and we had this beautiful dinner last night, but then very quickly things can turn very badly. I'm not quite sure what's in the butt waters, but I'm confident that it's dangerous. Well, then just yesterday I thought, this year I'm going to be different. I'm going to turn over a new leaf, and I'm really going to be good and not do what I did last year. So I'm walking through the French Quarter right off the airplane, and I thought, well, this is nice. This is a church. How bad can this place be? We've got a beautiful park and a statue, and here's St. Luke looking down on me. For crying out loud, he wrote one of the Gospels. It can't be that bad. And then next thing you know, I'm like, God, this is like a bad joke. Two Aussies, an Englishman and a Nebraskan walk into a bar. I don't even smoke. What the hell am I doing? And then who's this guy? I don't even like balloons. This is going badly. And then next thing you know, I just got out about a half an hour ago. So, really, generally speaking, I feel that we need to take ownership of our actions, and I appreciate being here. So moving on to the rotator cuff, there have been a lot of talks, and there's been a little bit of redundancy in terms of topics, and so I'm going to skim through some things that I had included. But successfully to repair the tendon, ultimately, it requires good biology, and that's really the future. Someday we're going to have a course where we're not going to talk one bit about mechanical constructs, but it's going to be all on how to augment the biology of repair and how to make things work at the cellular level, because that's really where the deficiencies are. That being said, for now, we are primarily in charge of the architecture and the biomechanics. You heard from Spiro Karas today about pattern recognition, which is critically important, and we've all seen these exact slides this morning. And I would echo his thoughts that in my own personal evolution of performing the surgery, the largest shift, the most important shift, was spending almost all of my time in assessing the pattern and grabbing the tendon each way, moving it back and forth, and assessing where it belongs. And as you saw on multiple videos today, the way that we repair it, I would contend, is not as important as where we repair it, anatomically speaking. Modes of failure are manifold, but the most important on this picture is number 2, leading to number 3. There's lack of healing, and that leads to failure at the tendon-suture interface. Well, who cares? Well, the reason why is, as Matt Van Horn informed us last night, 1 million soft tissue repairs are performed each year in the United States. Not all of these are rotator cuff, of course, but in many things that we do, whether it be instability or whether it be the cuff, failure rates are high. So as it relates specifically to the cuff, does it actually have to heal? Do you have to have tendon healing to have good function? And as we have seen in many studies, re-tear rates are high, but functional results are outstanding. The Galitsin-Yamaguchi paper is notable for the 94% failure rate, but what I think is most important with that study is it was one of the first papers to really objectively describe what we all know subjectively, which is that patients can have a re-tear, yet they clinically do very well. Well, why is that? It's because pain is generally not correlated with the size of the hole in the tendon. Pain is correlated by the nociceptic properties of the bursa, by the fraying of the biceps, by the acromial morphology, plus minus, if you believe in it or not. And so if we can address the pain, then a patient will be satisfied regardless of tearing, and that relates to really the crux of my talk is how do you make a decision in a patient who has a massive irreparable tear? So in that Yamaguchi paper, 100% patient satisfaction despite 94% failure. At 10-year follow-up in that cohort of patient, the pain relief was durable. This is what I found impressive. Buddy, I think one of your original studies many years ago, I might be misquoting you, but I think your follow-up on Rockwood's debridement patients had showed a lack of durable results if the tendon didn't heal, if I'm quoting you correctly from something 20, 30 years ago. And at least in this cohort of people, pain relief was durable, although there was tears obviously never healed, some development of radiographic evidence of osteoarthritis, but durable relief of pain. So what's the relevance as it relates to our day job, so to speak? Well, not a lot if we're trying to anatomically repair something, but what if we can't? We need to realize that the most important predetermining assessment is a preoperative appreciation of the multiple biologic factors, the tear configuration by imaging studies, and then the patient factors, and I would contend that's the most important. So Ashish Bedi helped us by defining the irreparable tear, which is the presence of a massive tear with static cranial migration of the humeral head, a reduction of the acromio-humeral distance, and atrophy or fatty infiltration greater than 50%. So if an anatomic repair is not possible, there are many different options at our disposal, a few of which are going to be discussed in more detail right after this. One can do an arthroscopic debridement, can do a partial repair, a plus minus suprascapular nerve release, graft or patch augmentation, SCR, tendon transfers, and eventually reverse total shoulder replacement. I would propose that if non-operative options fail, and if a person has what is determined as an irreparable tear, that what's really important is to do an assessment in your mind, and this is really based on time, getting to know your patient, to figure out what is their primary disability. People come in here, Paul Huseman described very nicely today how we think about the asymptomatic cuff tear. This is the opposite. This is the symptomatic tear that we can't fix. So therefore, I think you need to determine what is the primary disability of that patient. If the primary disability is pain, that leads you down one algorithm. If the primary disability is weakness, that leads you down the other. And in my experience at least, usually those two are relatively distinct. Usually it's more one than the other. And so if pain is primary, then I would consider the least invasive pain-modifying procedure that maximizes midterm success, acknowledging that long-term success is going to lead somewhere else. If weakness is the primary disability, then consider the procedure that restores function most reliably while burning fewest bridges. So pain primary, options are arthroscopic debridement, plus minus partial repair, restoring the anterior posterior force couple, and plus minus suprascapular nerve release. We haven't talked about that a lot. If anyone wants to play around with that in the lab, I'm sure all of the faculty are facile with that, and I'd be happy to help as well. That is another topic which I think would be interesting for another course perhaps in terms of how to implement that in these patients. If weakness is a primary disability, be careful to differentiate, of course, antalgic from true weakness. Don't forget the near impingement test with a diagnostic injection of a large bolus of lidocaine. You examine them 10 minutes later and you see what their function does. There's graft patch augmentation. We're about to hear about SCR, and Mike Terry nicely discussed tendon transfer already. So outcomes of debridement, well, there has been proposed a so-called ideal patient with that irreparable tear. There's lack of significant arthrosis. The patient's not suitable for tendon transfer. There is significant pain, again, as primary disability. There's a functioning deltoid and CA arch, critically important. On any of these, you need to assess whether they have anterior superior escape, advanced age as well. Results are mixed with debridement, but it can certainly be helpful, again, by the Rampage concept of removing the modifiable pain generators, distal clavicle, bursa, biceps, etc. The rotator cuff repair with pseudoparalysis, and an interesting diversion proposed by Steve Burkhardt, is that in the right patient, and they, in my opinion, somewhat creatively defined pseudoparalysis, but nonetheless had excellent outcomes in a partial repair or as much of a repair as they could, even in that patient with significant atrophy and with preoperative pseudoparalysis. So that's an interesting paper to consider. To my knowledge, that hasn't been repeated yet, but it was relatively recent. SCR we're about to hear about, so I will skip through that. Graft patch augmentation as well may reduce gap formation, facilitate healing. The type of patch is important. Tendon transfers, again, we heard from Mike Terry, and Dr. Gerber has shown us that what's critical for tendon transfer, typically speaking, is that the subscap is intact. But that procedure does have a role for the right patient. And then lastly, reverse total shoulder replacement for the older patient, lower demand, and there are concerns obviously about implant longevity. So in conclusion, again, I would propose that in choosing your patient and their procedure, we need to predict what their goals are, really not predict, discuss with them what their goals are, and differentiate them into those two broad categories of pain versus weakness. And the history is that critical factor. Really, most importantly, is in the red, you need to manage expectations and manage risk with the patients, because no matter what you do, you're just primarily going to be setting them up for a second operation later down the road. So this is my family. I just wanted to acknowledge them. Thank you very much. And have a good day.